really with psychiatry, it's just going to be like, what unit am I walking into right now? What patients got triggered? How many 1-to-1s and 2-to-1s do I have? And that's going to dictate how your day goes.
Yeah.
Because
Psychiatry. What did a typical day look like for you as a nurse?
that depends on the day. That's the fun thing about psychiatry. You never know what you're walking into day to day. It just kind of depends on what your unit looks like. So let's say I have a less acute unit. So that was a hard thing about child adolescent psych. When you get to adults, they like kind of like section off mental health stuff based on acuity level. When it's child adolescent, it's all one. So I would have super aggressive autistic patients at one day, and then on the same day I'd also have this like super easy depressed 13-year-old. So it's like you'd have like this super big gap. Like a typical day, like, you know, like a day where you have like maybe 1 or 2 super acute patients, you know, it would kind of look like you show up for work. Some psych wards are 8, some psych wards are 12. It just depends on what hospital system you're working for and, you know, how smart they are. And I can go into the benefits of 12s and 8s later because there's a lot to go over for that. So, you know, you clock in. You generally have time to sit down on a computer, make your assignment on Epic or whatever charting system you're using, scout out your meds, like be like, hey, I give them these meds at these times. Because the nice thing about psychiatry, it's usually with meals, like, and at bedtime. That's when you give your meds. It's not like randomly sanctioned off through the day, like when you have IV antibiotics or IV heparin or whatever. Like, it's just like, oh, they are taking Abilify at 7 in the morning and then at bedtime, and that's all they have. Great, cool. Maybe I'll throw in some
wake them up in the middle of the night for an antibiotic.
Yeah. No, you don't have to wake up in the middle. I mean, sometimes if you get a diabetic patient, you have to wake them up in the middle of the night for a QC check, but that's about it. So that's kind of where the benefits between 12s and 8s kind of comes in, because if you're doing a 12, you get to have some interaction with your patients, whereas if you're an 8 and you're on night shift, which is 11 p.m. to 7:30 a.m., you don't wake up your kid. You let him sleep. You don't even have to worry about doing an assessment. Like, it's usually unable to assess patient sleeping. And it's like, I'm not going to wake up a patient and ask them if they want to kill themselves. Like, no. Like, you know, you have to lay eyes on them and do like your safety rounds, but like your safety rounds is like, you look in the window, are they breathing? Is there anything around their neck? No? Great, cool. Let's move on to the next patient. So like I said, it kind of depends. So usually you have time to scout out your meds, then you just kind of go and you'll go and like talk with, you know, your patients. You know, you can do the whole hierarchy of needs, or if you have that one aggressive patient who just got IM'd and is sleeping, you save them for last because you want them to sleep. It's great. So, you know, you go and you do your assessment. You can kind of do your assessment regardless, like, you know, just depending on where you're at. As a guy, personally, I would always make sure I would do my assessment where there's cameras. Because all you're doing is talking. You're not doing any physical examination. Just talk with the patient. That's all you do. So I'll make sure it's either I'm in an area where there's cameras or I'm in an area where I can be seen by staff and cameras. Like our outside area that I work at, the unit that I worked at, had cameras and these giant windows that if you walked past in the main hallway between the day room and the patient rooms, you couldn't miss anyone that was outside. So it's always pretty strategic to do that, because you will get those patients that make false accusations about things. I don't know of any that were made about me. I don't think there was any made about me, to my knowledge. But that's the beauty of psychiatry. There's security cameras everywhere. So, and you know, that's kind of really what you do. And then you do your med pass at your days at the times that it's due. And, you know, that's kind of it. Like, you can kind of, after you do your assessment and after you chart, you can just go outside and play dodgeball if that's what the recreational therapy group is, or you can go color with the kids, like, or you can go watch the movie with them, or, you know, if the kids and the visitors, and with visitors, you know, you just hang out with your coworkers, because like there's no one in the day room, no patients to hang out with. They're with their family. They can do their family stuff. So yeah, that would be a nice, normal-ish, easier day. Now, if you have a super acute unit, you can bet you're going to be in multiple hands-on situations. And what I mean by hands-on situations is your hands are on a patient to keep that patient from either harming themselves or a staff
Wow.
member or another patient. I can't even tell. It seemed like every day at my old job before I left, I was putting at least 1 to 2 kids in restraints every day,
Wow.
because it was that kind of an acute unit.
Mm.
Everyone, it was like the kids were super aggressive or super suicidal, because a restraint order actually can be for extreme self-injurious behaviors. So if I have a patient that's got a sheet tied around their neck and they're trying to cut up their arms with their fingernails, I can put them in restraints. That's a rationale enough for me to put them in restraints.
Yeah.
So I don't know if, at least at the hospitals that I've worked at so far, that has been a rationale for a restraint usage, is if they are actively suicidal and actively trying to do something to kill themselves, and it's like an absolute immediate danger, you can restrain them.
Well, there needs to be something to kind of de-escalate them.
Yeah, I mean, generally when they're in that headspace of I'm tying a sheet around my neck because I want to die, there's not a whole lot of chances to do a verbal de-escalation. Sometimes if you have a good rapport with that patient, you can, or like a good relationship with that patient, you can maybe go in and be like, what's going on? Like, I have a sheet around my neck. What does it look like, you idiot? And, they'll say some sassy comment like that. Like, well, let me break it down to you right now. What's going to happen is I'm going to have 4 or 5 staff members come in here. We're going to take off all the linens off your bed, because you can't be trusted with linens because you have a sheet around your neck.
Mm-hmm.
You're not going to have a pillow either, because, you can tear up the pillow, use that to hang yourself to. And, you're going to be in the gown and also be, cold and miserable, and probably sleeping in the seclusion room, because we can monitor you in the seclusion room because that's where the cameras are. That works great sometimes. It doesn't work great other times. And like, obviously there's different degrees of having a sheet tied around your neck. Like, if it's pretty loose and you can see like the patient's neck and like there's like a loop there, okay, you can do that. But if it's like tight, it's game over. It doesn't matter. Your hands are going on that patient with other staff, and you're getting that sheet off because, airway.
Yeah, safety.
That actually did happen one time when I was an assistant on the floor. I was getting a report from one of the other staff members, because the kid was on a 1-to-1. Right. Another thing about psychiatry, depending on your acuity, there are patients that will have 1 staff with them at all times or while awake, and there's patients that will have 2 staff with them or at all times or while awake. And in some really rare cases, especially with adults, you'll even get 3 or 4 staff with 1 patient while they're awake.
Wow.
There was one dude who was manic who almost killed a staff member. Ended up being a 3-to-1. This wasn't on my unit. This is when I was doing my externship at the hospital that I also ended up teaching at. That had happened to another nurse, and I was like, oh boy. I was just playing ping pong with that guy. Oh boy. The dude that we ended up having to restrain was like some sort of judo instructor or something like that. So he was manic, and which, when you're manic, you also get like what seems like superhuman strength.
Mm-hmm.
And you're delusional, and it just doesn't end well most of the time. So there's a little bit more physical danger in the realm of psych nursing as well, to keep that in mind. And as a young 20-something-year-old guy, I got a lot of the super acute patients because they're like, here, because I'm 6'3", 200-something pounds, like, no teenager's gonna really mess with someone that's that size,
But yeah,
whereas
like, there's a lot of girls in nursing, and so I know from my personal experiences, if I was ever having any behavior problems, if there was a guy working on my unit that day, I was recruiting them to help me, because it can get pretty hairy.
Yeah, and and that's actually, so for any guys that are watching the podcast, if you want to have a lot of other guy coworkers, mental health, there is a ton of dudes that work in mental health and in emergency medicine. That seems to be the biggest population of guys in the nursing world, from what I've seen, and probably ICU, because I feel like ICU is like kind of that setting too. But that's where I've seen the most other guys working. Really, with psychiatry, it's just going to be like, what unit am I walking into right now? What patients got triggered? How many 1-to-1s and 2-to-1s do I have? And that's going to dictate how your day goes.
Yeah.
Because even if that 2-to-1's not your patient and they have to go in restraints, it's not a you call security thing. Well, I mean, it can be, but it's like you call security, but also your staff
All
that are
hands
there
on deck.
are trained to go hands-on and will go hands-on with you so you can restrain the patient to prevent further harm. And, you know, security can get there in time, great. If not, oh well, person's in restraints. We're qualified to do restraints. We've been signed off on competencies to do restraints. So there's that.
Yeah. And sometimes security, there's a delay. So especially depending on the severity, you have to act without waiting for them.
Yeah. Sometimes what would happen on our unit is it'd be me working with a bunch of other smaller girls, and we'd have like this 300-pound patient we'd have to put in restraints. And we were holding them on the ground, never on their belly, but like on their back. Because, you know, when they're on their belly, you can compromise airway, but if they're on their back, a little bit less likely. And we're like, we can't lift this patient. Like, so you call security and they usually will come and help you out. But yeah, and sometimes having another interesting thing with psychiatry as well is like what you can learn, and also like even the regular nursing world when you have a behavioral patient, is when you have more people, more of a show, the patient acts more grand, like they put on a bigger show. Whereas if you dial it down to only the bare minimum of people that need to be in the room, they're usually a little bit easier to kind of redirect, kind of thing, like easier to redirect, or you can calm down, or you can help, or they can sit on the gurney for you, versus, and that's the kind of thing, because psych nurses are supposed to be trained to not enter into what's called power struggle. So power struggle between a nurse and their patients would be like, especially with teenagers, would be like, you know, like let's say there's a teenager that's attempting to punch patients. Be like, there's like, you can't punch patients. Be like, well, yeah, I can do whatever I want. I'm a teenager, you can't do nothing. I'm like, well, and then you can actually throw some fun facts at me. Like, actually, if you hit any of us we can actually charge you, you know, for hitting a nurse. And you can go to juvie for a little bit if that's what you so choose. Sometimes that escalates them more, sometimes it'll de-escalate them. And you know, with those patients, it's just a matter of like, no matter how much you want to meet, so like they're up here, right? They're like up here going 100 million miles a minute, super agitated, super whatever. You can't come in up here because then they're going to go up here, which is, you know, way off screen. You have to come in down, like way down here, like, you know, come in calm, cool, and collected. Just be very blunt with your statements. Don't engage kind of like with the behavior. Like if they're like, let's say they're like scratching their arms or whatever, and you're just like, okay, like what? Like you're not going to kill yourself by scratching your arms. Like, I mean, we can talk this out, or we can, you know, like put you in mittens if you really so chose for us to go that route. Like, you know, there's that option.
Yeah.
It's very important, especially with psychiatry, to kind of just be like, you know, I understand the patient's up here, and I tend to want to meet that here, but you cannot do that when you're a psych nurse, because it's just going to escalate the situation even worse. So,
Well,
yeah.
thank you so much for your time, Josh, and being able to be with us and talk to us about psych nursing.
Yeah, of course. I had fun talking about it, you know. If you need someone to come talk about psych nursing again, I would be happy to come and do it.
Life is a winding road, no telling where it goes.